I guess I'll go up here. I have this. Can you hear me now? Okay. So I want to welcome all you fine people. In the past couple of days, I have been very gratified to know that I work with such a great group of people trying to bring social equity and justice to our community. So thank you for the work that you do. And so I'm going to ask you to be patient and go on a little walkabout with me because at the end of last year, our organization was asked to be the project manager for one of the 104 planning grants that the Oregon Health Authority gave out to groups across the state. So can I ask if anybody else here received one of these planning grants? Okay, so you know what we're talking about. And so when we were invited to do this, the group that invited us consisted of Marion and Polk County together, facilitated by the CCO, with 40 plus members in the group from law enforcement, courts, judges, social services, CMHP, behavioral health, hospitals, services to the homeless, and services to corrections. And so we came on, and at the time, OHA had very few staff to manage just 104 planning grants across the state. And the scope of work was a little mysterious. So we tried to establish what that was with the group. And over time, we began to realize that all the people in the group wanted one thing: housing for people with serious and persistent mental illness. And all of them were service providers, and none of them wanted to develop, own, or manage housing, but that's what they wanted: housing. And so the light bulb came on in the room that we were the only housing voice in the conversation. And it became Mr. Froggy's wild ride. And so over time, I began to realize I needed, as a person, to understand why this was such a problem. I mean, what did it mean? So this is the group that we had. We had all the people at the top of the oval that were in the group, and they then wanted us to expand to the people under the oval. So all these other people came on too. And over here on the right, we actually had some people that did housing, and they were sort of new to the conversation. So then, how did we get here? How did we get to this problem of so many people with serious and persistent mental illness in need of housing? And what did community integration mean? What did that mean? So now you have to bear with me. This is the walkabout. This is a lot of information in my little PowerPoint, and I'm just going to read it to you. Okay. Is that going to be okay? I know everybody told me that. My son, who's a software engineer, said, "Mom, what about that?" And I said, "I can't do anything about it." So I'm going to tell you that because I didn't understand this, I started researching, and there's all this truncated information on the internet about community integration for people with serious and persistent mental illness. And I found a 70-page thesis done by a OSU honors student on the history of the treatment of the mentally ill in Oregon. 70 pages. And you know, the good news here is there's only 3 slides. So I'm going to just read it to you because I think this is very informative. So in 1861, Dr. Hawthorne contracts with the city, with Multnomah County, to take over the poor farm. And then shortly thereafter, at 12th and Salmon, there is the first facility for the mentally ill in the Northwest Territory established. And the interesting thing about this is he was a member of this association that was very focused on, with Quaker influence, how the mentally ill should be treated. And it was called a moral treatment, where they were supposed to live socially, have access to exercising grounds, have music, access to art. It was a very, I think, humane way. Is that me? Oh, I hope not. We'll turn that off. Okay, so
Next time I'll pick it up and give them some name. Like,
just tell them to call back later. Thank you. So this was a very well-received way of treating the mentally ill, this facility. And so then 1883, the state creates the Oregon State Hospital in Salem, and all the people from this facility at Southeast 12th and Hawthorne. And if any of you are here in Portland and you know that area, what's really kind of phenomenal is right now there is a big food court there, and the name of it is the Hawthorne Asylum. And it's actually got really good food, and it's really well put together. Is it? But it's interesting because I didn't realize it until after reading this, because I had been there for food in Hawthorne Asylum. Somebody knows the history. And so then the Salem Hospital is created in Salem in 1883. And when Dr. Hawthorne was in charge, there were about up to 200 patients a year. And then by 1900, the population grew to over 1,000 patients. And then in 1906, the Fairview home was opened separately to treat developmentally disabled persons. So then 1930s, there was an effort to have more community-based programs, but they were focused on children as an early method of intervention to prevent chronic illness in adulthood. 1940s, World War II pulls a lot of practitioners away, and with changing attitudes toward the mentally ill, there is a stronger movement toward deinstitutionalization way back in the 1950s. And then by 1950s, the population in the hospital in Salem grew to 5,073, prompting new facilities in Dallas, and in Portland. And one of the reasons that was true is because it was very common for people with disabilities of any kind to be sent to the mental hospital. And so that inflated the numbers. And then this also, and I think it has something to do with this large population, but the period moved into that very dark time of treatments that have now become unlawful. In fact, the last lobotomy was performed in 1981 here in the state of Oregon. And so in the 1950s, another effort to begin deinstitutionalization took place in Governor Hatfield. Does anybody here remember who Governor Hatfield is? Senator Hatfield later. Anyway, he started these community-based programs that have since become the CMHPs in all 36 counties in the state. So then we get to civil rights, 1960s. And so all these the 1964 Civil Rights Act outlawing discrimination or segregation in public accommodation based on race, color, religion, national origin, or disability. So then in the 70s, the Community Health Programs Act was declared in Oregon, and that this declared that community care is the most effective and humane way to treat the majority of mentally ill and what they then called retarded individuals. I hate to use some of these words, but that's what was in the study. Okay, so this then established 3 areas in the mental health program in the state, which was alcohol and drug, mental illness, and developmental disability. And then in the 1980s, Oregon passes the Mental Health Services Act, requiring that all mentally ill be treated to the greatest extent possible in the community. And then this came just after the passage of the Civil Rights, the CRIPA Act in 1980, which was intended to improve institutional care by requiring treatment to be delivered in the least restrictive manner, which is a key principle of the Oregon Health Plan. So 1990s, Americans with Disabilities Act, again, most integrated setting, least restrictive. Community integration is not only important for individuals and communities, it is also now the law. And then in 1999, the Supreme Court held that unjustified segregation of people with disabilities constitutes discrimination in violation of Title II of the American with Disabilities Act. That is the Olmstead ruling. So more than 60 years after an initial deinstitutionalization trend, even with federal law requiring community-based care, we are still struggling to map a path forward to this end. And for me, I needed to understand this because the state has been sued repeatedly. I mean, you out there probably know more about this than I do, for not meeting this legal objective of community integration. So this right here, I think, is at the crux of where we are in moving forward to community integration for people with serious and persistent mental illness, the Olmstead ruling. I mean, is there anybody that knows something about this that they'd share? You know a lot about this, Sue.
Well, it's just state.
They haven't done real well with it. And so I have to,
They're supposed to do it even if they can't, right? I mean, there's some kind of clause like that. All right.
and so for me, thank you for going on this little walkabout with me, because for me, I could not understand why the state is repeatedly being sued for not meeting what I didn't even know they were supposed to be meeting, which is this. And I think these elements are very key, that the services are appropriate, that the person chooses or does not oppose. It's not like they don't not choose, but they do not oppose community-based services, and that the services can be reasonably accommodated given the resources available. And that to me is very important in being successful with supportive and supported housing. So here we are, design and modeling. Isn't this a lovely slide? Say, in my mind, if we are housers with housing that we want to provide housing for a certain number of people integrated into our housing community, so who designs this model? When we were working with this large group, they kept telling us, just show us some models, just show us some models for housing. There is no physical model. This is a cooperative model that requires collaboration between providers and housers. And so it requires clinical, service network, user group, property owner. And I think there's a process here. How are people referred? Not everyone with serious and persistent mental illness at whatever level of acuity can be appropriately housed in off-site supported housing. And we don't have enough facilities in this state to serve the higher levels of acuity. So we can talk about models all day long. And when people go through these, like the Oregon State Hospital, and get released, where do they get released to? Where do they go? But that problem at the upper level is not what we're here talking about today. We're talking about supported and supportive housing for people who can live with supportive services and reintegrate into the community. So I wanted to take this minute to introduce ourselves in the panel and you nice people in the audience. And so my name is Diana Satanovich. I work for Polk Community Development, which is a rural nonprofit serving Polk County, but in this case, working with Marion and Polk County. And Marion is a very big county, and Salem is the second largest city in the state of Oregon with a lot of homeless people. And so I'm going to ask each of these nice people to introduce themselves and tell you a little bit about what they do.
Hi, everybody. My name is Jim Halva. I work for a company called Cascadia Health. Okay, microphone.
I think we have to turn it on, Jim. That's okay.
I'm really tech savvy. Can you hear me now? All right. All right. Okay. So my name's Jim Halva. I work with a company called Cascadia Health, which up until a few months was a long time was called Cascadia Behavioral Healthcare. I've worked with the organization for probably 35 or so years. I go way, way back. I was telling Diana one of my stories, and I could tell her, I know you all kinds of stories, but when I first started, I had a field placement at Southeast Mental Health, which ultimately merged into Cascadia. The job that it was a student placement, and part of the work was we would go to somewhere around Portland State University on Fifth Avenue and wait for the damaged bus to show up. And we had a piece of paper with names, and we yelled out for them, like, Leslie Ford, are you here? We've got something for you. And but that was kind of the nature of mental health services back then. It was very, very
Ground level.
yeah, well, and institutional, and not a lot of thought, planning, or coordination. I mean, imagine that, trying to just yell out and on your piece of paper, and then find people someplace to live somewhere. And so I feel like it's a story I like to try to tell, because most people probably haven't experienced that or gone back that far. But we've come a long way, and we have a long way to go yet. And I also had some really great discussions with Diana. We must have had about 5 or 10 phone calls or something. It seemed like a lot of good things, but I really liked hearing about this project. So I'm going to send it on.
But Jim, one thing I'd like to ask you is, Cascadia Health provides both supportive and supported. And the reason I distinguish those two is because when I was talking to some people about this, I think when we try to lay out what is needed, supportive typically is housing for people with serious and persistent mental illness that has in-house services, on-site clinical and social services supports. Supported is housing that has services, but the services are off-site and brought to the client, or the client goes to the services. So in my mind, that's important to distinguish, because many of us develop housing and we're housers and we don't have services in our organization. And so we have that supported housing where we have to rely upon our partners in the community. And so Jim's organization has both supportive and supported. So I think he has insight into the kind of services that are optimal for the success of the individual. So is that right, Jim?
Yeah. Yeah. And the other thing, I was doing a count of the buildings and units. So Cascadia Health owns or has some connection to 790 units and 40 buildings within Multnomah County. And we've been very fortunate to come upon many of those things by an organization didn't want to do housing anymore. Send it here, we'll do it. And then we've had a number of tax credit buildings that we've worked on, and any kind of funding you can imagine, bonds, elderly and disabled bonds, over the years to put these buildings together. And that these buildings are predominantly housing people who have serious mental illness. And the last thing I'll just say is we've seen a tremendous success in people in terms of their life and moving ahead with the varying kinds of supports and having hope for people. I think that the hope part is a really essential piece in it, believing that people can and will get better. So more to come, maybe.
Absolutely. Thank you.
Good afternoon, everyone. I'm Kenny Lapointe. I'm the Executive Director of Mid-Columbia Community Action Council. We serve Hood River, Wasco, and Sherman counties through housing assistance programs. We operate 2 shelters, approximately 60 shelter beds in the region. I would call them supportive shelter. We also provide veteran services. I don't own 700 units of supportive housing. I have 10. So quite a bit lower, 10 supportive housing units for formerly homeless veterans. I was previously, before I came to this position a couple of years ago, I was the public affairs director for Oregon Housing and Community Services and worked with Sue and a few others on the Medicaid waiver, which was just approved yesterday. After I don't know how many years, Rachel probably would know, but it was many years of work to get a waiver that would help fund supportive services that support homeless or formerly homeless individuals. So there's a lot to be said about that, but we have a lot of time to think about that because it doesn't go into play until 2024. But yeah, that's me.
Thank you. I'm Nicole Youths. I'm the housing administrator for Salem Housing Authority. And we are the ones that develop, build them, and put them into service and manage them. And we really reach out there to try to find the service providers to come to our facilities and do that portion of it. We've really worked hard to know where our expertise is in what we do every single day and find those that are the experts to come to the sites and do the supportive services. We had a dream many years ago to build a permanent supportive housing in Salem. And with collaboration with the Mid-Willamette Valley Community Arches Project, we were able to bring Redwood Crossings to light. And that project's been in service for, Jessica, how many? Oh, we opened in the wildfire, the Beachy Creek fire. So, and it opened in one of the most difficult scenarios with COVID, wildfires, ice storms, pretty much anything you could have happen has happened since that building opened. So we are fully leased up in that project quite often. We have a collaboration with Salem Health for transitional respite units. We were hoping to have a better model. This is a growing pain and it's a learning experience. Every time you open one of these, your first 12 months is really that learning curve. I think that Jessica Blakely over there, who helped open that project, we had many nights of who's taking the calls tonight. So expect that to happen when you open one of these new ones. We are now on to our third project. We have Yaquina Hall currently under construction on the old state hospital grounds, the nurses' quarters, the former nurses' quarters for Oregon State Hospital. And we're historically preserving that into 52 one-bedroom units with serious and persistent mental illness as a preference. And then on top of that, we're hoping to close Sequoia Crossings on October 21st of this year, which is 60 apartments of permanent supportive housing. Each of those, we have had to sit down and have tough conversations about MOUs and make sure contracts are in place, that people are in place as soon as those doors open. If we can't make that happen ahead of time, we're not doing the building justice or the residents moving into those buildings justice. And going back to opening a permanent supportive housing in COVID when nobody's supposed to be working in offices and nobody's supposed to be face-to-face, can be a challenging hurdle that we had to overcome, including paying off our loan early to that one so that we could stabilize the project on its own, pay for more security, and try to make adjustments. So there's definitely uniqueness, and we're happy to be here and help discuss any of those projects with any of you.
Thank you. Hey, Nicole, let me ask you one question. So I asked you, back to Nicole. So I asked you once, when do you start discussing the model, the housing model for this population in order for it to be successful? When do you start doing that? I think you told me that you start at the design level.
Absolutely. My architect for Sequoia Crossings is here, and she's also happy to answer any questions, but every moment of that development has been, from the day she met with us to design it, had been what is the best trauma-informed practice, what is going to be the best materials, what were we looking for in the project. I kept telling her, make it calm, keep it calm, make it calm, put some more water features. I don't know what we need to do, but let's keep it calm. So they have done an amazing job at designing that project, but they have been along the side every step of the way.
But also the service providers, were they at the table at that time as well?
Yes, absolutely. Arches has been at the table since we went through the Permanent Supportive Housing Institute. So they came alongside us before before we got the design concept, and we started talking with them about Sequoia Crossings and building this and what they wanted to see in a supportive housing project and what we wanted to see in a supportive housing project. But they have literally gone in on every application and everything that we've done step by step alongside on this one.
How about you, Kenny? Is that your experience as well?
We are typically engaging all of our partners before we get to the program design phase. But that is the same practice we have where we're working with an architect and pulling together the partners. We're doing that. We've done that on our navigation center project, which we talked about this morning, pulled together all of our partners and went through design and programming with them up front. It's really important to get everybody else on the same page, to discuss trauma-informed design, which I think is really important when you're doing projects like this. So you have, I don't know if the calming is for the clients or for us. So, right. I have this on my desk. I have calming blend doTERRA oils, and I'm constantly rubbing it on my arms. But I mean, I think having that trauma-informed design is really, really critical. It is critical for us, right? Like coming into a workspace that feels like a good place to be on a day-to-day basis, it makes the clients have that same feeling. And I think it's really important for us to do that up front. Even more important for me is from a homeless service provider standpoint is to have your behavioral health provider at the table with you and willing to commit as much or maybe more than you to the project, because if they're not going to show up, then you're going to have a problem in the future. And homeless service providers are not behavioral health providers. Maybe some behavioral health providers have converted to homeless service providers, but we are not. And we need those partners at the table. And I think it's really important to outline agreements with them up front, agreements that are lasting, so that if you have a change in leadership at either level, you don't result in a change of project support. I think there's other folks in this room that could tell you about projects that fell apart when the behavioral health provider decided to pull the plug, and that doesn't help a lot. And it causes it fractures relationships in the community, and it really harms the ability to do more supportive housing projects in the future.
So Jim, do you want to say something about that? Cascadia has both supportive with in-house services and supported with off-site services coming. So how early on do you think it's important to engage your service, behavioral health and other providers?
Well, I think the thing that we have, I mean, we have the services in Cascadia, so it's a matter of reaching out internally for us. And that's not always easy because folks have other jobs or things that they're doing at the moment. And you know, I think of we come from a couple different cultures when we're talking about services and housing, because sometimes each of us don't know the other very well in terms of what your model is, what you need, how do we get there, and things like that. So I think that's something that takes a lot of work. Even just being like, I know the people that are going to be doing this, but we can struggle kind of getting on the same page about it. But so we start early.
Yeah,
Early.
I think that was a very pronounced experience I had with this group, is how little they knew about us as housing people and how little we knew about them as service providers. And because one of the first things they wanted us to do as nonprofit housing developers is develop, because they were so desperate. I mean, I really had a lot of empathy for these frontline workers. They were passing out tents and sleeping bags to people because they had no place to put people. And I'm sure you've all had those experiences. And so I think that times have changed with staffing shortages and other things. I think in many ways, we have to ask those providers to move closer to us, and we have to move closer to them, and maybe start with trying to understand what their limitations are, what our limitations are, and build our design from that capacity, that understanding of capacity, because there are significant staffing shortages within the healthcare industry. And so, anyway, so here's one thing we talked about, which is, if you stop and think about the population that we're looking at, homeless and people from corrections, moving into an independent living situation, basically. And so, homeless people coming from wide open set of rules, people from corrections coming with all rules, and then they transition to this new housing situation. The question is, it's starting at the beginning. I have a big question about how are people referred? What's going on, my friend? It's not moving. Thank you. So understanding the population. So the groups we were looking at in our planning grant work were the homeless, the chronically homeless, people from transitional shelters, the aid and assist population. I'm sure that you know who the aid and assist population is. We had judges in our group that would see up to 10 people a month that qualified under aid and assist. And during this whole staffing scenario, they at one time had contracted with an entity to assess these people for where they could be placed, which again, where is that? And then they lost that. And so they were asking someone to come forward and assess these aid and assist people, because some of them have developmental disabilities. Some of them have different levels of acuity with mental illness. So knowing how to provide them what they need to move forward in the aid and assist population, because they were so unable to manage their legal situation in the courts, was a problem. And then corrections, and the crisis center, I'm going to say more here. Here's another one of those bad examples of PowerPoint, right? Yeah. But that's okay. You can. It doesn't bother me. Yeah. So Oregon ranks 4th highest in the nation for the percent of chronically homeless people who are unsheltered. And more than 2/3 of chronically homeless persons are living unsheltered. The national rate is 51%. And the state of Oregon has been in a healthcare crisis for years. In 2022, Oregon ranks as 49th nationally for the number of adults with a higher prevalence of mental illness and lower rates of access to care, and 45th for youth. So this is from our Homeless Alliance. And this is in Marion County and Polk County. 4,326 persons assessed for homelessness, and 36% of them self-report with a mental health disorder, 30% with a physical, 28 with chronic health condition, 23 with SUD, and 20% with developmental disabilities. So these are a lot of very vulnerable people. We already have a shortage of affordable housing. So affordable housing for these vulnerable populations is at a crisis level, and we're just trying to figure out how to respond with optimal conditions to be successful. Because if we all have this experience, I think, where we get people in our housing with these kinds of situations, and they have an episode, they destroy the property. Our insurance in the past several years for affordable housing has tripled, so that we have thousands of dollars of damage. And on top of all that, we have a person that is back on the streets. So the focus in this session is to hopefully look at what elements will help us be successful in housing this population in supported housing. So this is the corrections. I get this information from the Department of Corrections, and that they categorize their populations as all of corrections, all the correctional institutions in the state. So they have 1,200 people with a highest treatment need for mental illness, severe mental health, 2,326, moderate, 1,773, those who would benefit from treatment, and those with developmental disability. And these are the ones that have been released to our counties in the last 2 years. So we have, several hundred people with mental illnesses coming out of corrections. And the question is, where are they going? And I could not get that data. I'm sure some of them are actually prescribed the state mental hospital, but people can't get into the state mental hospital. There's no room for them. That's why the state has been sued several times, because I think even OHSU just sued the state mental hospital for not taking people. There's no place for these people to go. And so again, we go back to this idea of, in order to be successful for the population we can serve, with the subpopulation within this large population, we want to be successful because we don't want to turn these people back to the streets. So that's what we're trying to figure out here. Oops. And this, all roads lead to the social determinants of health, right? So these are the big picture social determinants of health. And I'm saying we're at the point of who to refer to our housing. What elements are needed for that person to be successful? Because this comes, I think, along the way, but not in the beginning. Okay, so I am going to stop for a second and ask if people would break up into 3 groups and come to a table, or at least join one of the elements at this table. I can't remember. Could you tell me what that one says? Optimal conditions for success for a person with mental illness living in our supported housing. And there's nobody at the table to read that, but I think that says impediments. Key concerns and impediments, and this is advocacy. Yeah, because I think I had been working with 2 agencies, the Willamette Health Council, and I can't remember what NAMI stands for. And both of them have said, now with a new governor coming on, that means new agency heads in many cases. Now is a perfect time for us to identify the things that we would like to prioritize, to say to the legislature and to the agency heads that is needed to be successful in this effort. So that's advocacy. And so if you could join one of those groups, please. And one of these fine people is going to come to one of those tables and facilitate a conversation. And we need someone to take notes that will report out. And you have paper and pen. Is that okay, Jim?
Does it matter which one we go to?
You can go to since you're down the stairs first, you go to the one you want to. You want to go to advocacy? You want to go to impediments? Okay. Oh, so Nicole's going to go to optimal conditions. So the panelist is going to facilitate, but you need to choose someone to report out, and you need to choose someone to record. And if the report out person wants to be the recorder and that works best, then please go that route. Okay, so let the games begin.
Well, hopefully, you're going to talk about, being on, I'm gonna that's the biggest thing, so there's a lot of education. It's sort of the fun. And second of all, I think that first, the doctors are talking, they're too overwhelmed. Like, they're newcomers or they're immigrants, they don't speak the language, so many times, like, I kind of, you know, because they said she had a disability, but it was, she didn't have, she will have to want like, very but here, because she has so there is this connection from mental services. That's the time when someone has this concept of identity, how to use them and how to recognize them, whether they're someone that is but or someone that is just like breaking the barriers for one person to like and that happens in the word system everywhere, you know, where like this going there and they're like, oh yeah, this I don't want to deal with just like different stuff like there's a lot to say like for the families that want to there's usually like flexible so then like me, notice something anyway, they did it like they were like doing it from the registration and you say easily they still say that they needed to they actually fear because they're like, yeah, I'm having problems, but I'm not that sick or I'm not exhausted. Stuff like that. So I feel like many things that they don't stuff like that and they will like thousands bigger problems that I do. And I don't even like that's what I'm feeling this workshop because I want to talk about this. Get how they said big problem and I'm here to that's what improve the problem by so I was like in history. I was that and I am not there. One of the things that makes it amazing are referrals come from anywhere. You do not have a clinician, you do not have you can't enter. One of the big things that I only ever
I think that, that's part of the issue too. What happens with nobody's resting. Property. So you gotta figure out how to maintain. Otherwise. Not optimal. I'd rather optimal. Yeah, I guess that was obviously, yeah, like so very up there. In fact, I'm a long time, so I have. You have a question.
And it's possible to do that. Building. I don't know if there's something like this, like these should start. Oh, anybody, I come to school. You can discourage it because then you'll get their house. Very cool. So the line that he has all of our I think your CPO is probably about. The CPO you're gonna have to put somewhere else. Yeah. And that's gonna be like. It's gonna be the start of like. We're about to be a building. Community health. And also. They told me that. I haven't signed it. We need. So it'll be interesting to see what happens. Because right now, like the data that you were reimbursement interaction. So you have to have an interaction. To get a reimbursement. You don't get paid. Interact with a lot of people. Not interact with parties.
That require local care. Going to pay. And how. No, I want one little fine line. Really, really high. So let's talk about.
I mean, I can, you can still do PSA that is not for people with. SPMI. You can do.
Let's hook you up with.
Better.
So instead of coming to
Families with the fun. This is definitely.
and they don't.
And the most.
We're not just like in the house, you can go outside. As long as you're in a house. And that they are, a lot of people even then they start like. Eating a bunny. And then they become. And then we, okay, I'm ready now. They're both now. We need to actually work with the lady. Unfortunately, when we fail, that we get correctly. And. I'm so curious what's going on. Any sort of sustainability have input. We're from the artist. You know, yeah, we're something, but also. Like if someone. I really have more of the ability made, but that's not a little bit. And people don't wanna. Yeah, that's a lot of what people. Is about it. It's part of the. Part of the. Finding the back of the project. We don't really have any like. Ground level. Solutions. Oh, I was thinking this was. Yeah, I don't know, more money, like, I know that, like, yeah.
I think. There might be a slide on there.
I mean, like,
I think.
my ideal is.
Before the meeting. People.
Oh, they're gonna start to put back in the project. So not just like.
Yeah, but now.
That's something to like. Done a little extra time or a bunch of. To make. Look a little bit. Look nicer, sort of have this disparity between. Work out of the supportable housing and regular housing. And to have everyone understand that it's an investment in the community and an investment.
AV person,
It's like 6 years.
Yeah. Yeah.
CSH.
So our.
excuse me. So this is my favorite part when you all are in the working solutions mode, but in about 2 minutes, I would ask that those who are reporting out come up and report out what you have identified as priorities in your group. Thank you.
buildings where all of those are around interior. Real bad. Yeah, just down the hall. Yep, down the hallway, yeah. And they're like, I've been. By the way. Yeah. It's not every single one of my page, and I actually found it out.
Yeah.
Oops. Okay, I'm gonna start singing in a minute. If we don't pay attention and get ready to report out. 1 minute to report out. Who's your reporter? Okay. Got to start walking, Sue. Got to start walking over here. Well, it's 4:15 and you guys can stay here as long as you want. That's okay with me. Thank you.
Oh, yeah.
Okay, so for you people who are reporting out and are worried that you may not be experts, I'm going to tell you my favorite joke. It's probably the only one I ever remember. You know, I grew up in a logging camp till I was about 9. And then I lived in Seattle. I lived in San Diego. I lived in Portland, even lived in San Francisco for a while. Now I live on a farm. And my favorite joke is, what is an expert? A person outstanding in their field. Is that not about as dorky as you can get? Yeah. Okay, so who wants to go first? Would you like to go first, sir? And panelists, you want to come back up and sit down, please? Thank you. Okay, I'm going to move out of the way.
So we were the impediments group, and yes, I'm one of the people that doesn't know enough to adequately report back, but I'm going to do my best. We started, I think, by discussing the right to decline services being a sort of core problem, and the flip side to it being service providers dropping out of providing service without communicating that they're doing so. People being referred without the necessary support being behind that referral. Nightmare story of DHS referring people, and by virtue of getting them housed, that means that they were no longer responsible for them. So that support went away. There was sort of a tension between the idea of wanting to draw together a lot of service providers to make sort of a net, but also the need to have like centrally accountable people responsible. And then communication with CCOs in order to engage legislators. This is where I started to get fuzzy. I don't understand this stuff. And then engaging the new Medicaid billing. Some impediments came up there. Reimbursement is going to be interaction based, and you only get paid for one interaction per month per client, it sounds like. So you don't get in-depth support through that kind of method. Anything else?
Great job.
Okay, my group has advocacy. So we thought long-term ongoing funding for supportive services, which are 24/7. So a lot of the trainings that we took and a lot of the classes we went through never prepared us for what came when we opened the door and then realized we needed 24/7 services. And so really understanding that upfront and building that upfront and getting the funding to support that upfront would be great. Another one is insurance. That's probably our top one. If we can't get insurance, we can't run these buildings. So Portland has their mitigation risk pool, and I feel like that needs to be statewide. Somehow there needs to be a pool of resources which come down. Maybe it's federal, maybe it's state, maybe it's a combination, but that's available for all PSH service providers and landlords on an ongoing basis to combat those rising costs, and maybe provide some type of way to self-insure. Capacity funds for cross-training trauma-informed models, adding social workers integrated into property management, and really understanding that there's a need for additional personnel, maybe some consultants to help train those on-site staff, and a support team, which would come from ongoing support for capacity. The next would be training opportunities for a new way of property management, because I've been in property management for 22 years and there's nothing that prepared me for opening our first PSH building. Am I qualified to answer a call in crisis at midnight as a landlord? Not at all. But we did get through it and we have made lots of strides, but really need to rethink what property management looks like for permanent supportive housing. The other item was potentially finding dollars that follow the person. So what I mean by that is identifying some statistic that we have out there, some data point that can identify how much it would cost to follow one person for 5 years through their transition from wherever they were to wherever they're going to go next. And then maybe in a graduating to see that, that gets less and less each year as we build in those supports around them. So it's not just the people who see them for the first time responsible for the full amount of support, but that can be customized by person with some form of identified dollar amount for each individual that we're serving. And report back on that. And then the other part is dedicated peer support funding that is a pool resource that is available for interested parties, for people who want to be peer support and be peer support for their communities, to get them through that education piece for peer support and to really identify some incentives to keep that pool growing, because as my group indicated, that peer support is probably the most effective form of support for these individuals, especially when they're in crisis.
Again, not technical. I'm communications manager, which means I can communicate about general things. I'll do my best. But we talked a lot about, so we were optimal, pie in the sky. We talked about cultural competency and language access offered at the sites, at all sites, including acceptance and embracing of diversity, being accessible, and that kind of feeds into the competency aspect of being available, like physically available where people are at, so that travel isn't a barrier. Low barrier in general for access. 24/7 assistance on site, and that could be clinical in some aspect, or people who are prepared to offer connection to clinical services. Trauma-informed policies, including lease agreements, tailored to the expectations that people have of the various levels in the communities. Multiple models of housing available for different needs, so that people know that there are specific places that they can go if it's not the right fit for them at that location. More workers, less turnover everywhere. How do we get them to stay and invite their friends? More room at the state hospital or more state hospitals, because everyone's talking about there's no room there. Investment in projects being compelling to investors. So creating an enticing way for investors to want to participate in housing projects and invest in these in this area. And then a more robust safety net overall. And then on just a very wide range, identifying housing as a human right and having everyone actually believe that at all levels, from the general public to the highest levels of government, so that we don't have to have this conversation about funding or placement in general. So I don't know.
Great job. I mean, just the most excellent ideas. And one thing oh, sorry. Well, that's what I was thinking. If you could allow me to take a snapshot with my phone of your reports, or if you're willing to part with them, it's up to you. Well, they can just scan them to me. I don't think they want to type them out to my email, but I'm happy to give you my email. But I would love to keep them, yes, because those are some great ideas. And one thing that jumps out to me is this business of cost benefit. I think Kenny, when he was doing health and housing as the housing integrator with Oregon Housing, I looked at his old report that he made to the legislature, which was quite good, Kenny. Anyway, he had in a table the cost per night for being in the Oregon State Hospital. This was like 2019 or 2018, something like that. 19 cost per night for being in a strike was $800. Cost per night for being in a secure residential treatment. I can't remember what the price was, but you get down to supported housing. It was in 2019, it was like what, $36 a night?
64 to 80.
Okay. And so
13.25 a night. State hospital.
anyway, the thing is,
Not $13.
yeah, right. That's very low barrier. Anyway, the thing that jumps out to me is that I had been thinking when we get a little bit farther, where do we go from here? Is that really we need to do more of that cost benefit analysis because that will speak to the legislature. I mean, intuitively, they know it's less, but more important perhaps than the data of the number of people with this prevalence is the cost benefit to doing this successfully. So I have a plan to reach out to the university. They have, maybe some of you are aware of the RARE program. Has anybody here ever used the RARE program? Regional Assistance to Rural Economies. They give you a 1-year grad student from University of Oregon. We can get grant money to pay for that. And I want an economics student, grad student, to do some cost benefit analysis, because I think that's very important in terms of advocacy. The other thing that jumps at me, these are such excellent reports. I do want copies of them, if it's okay with all of you, is that like, where do we go from here? We have advocacy work to do. Like I pointed out, the 2 industry people that I talked to said, this is a good time, new governor, new agency heads, legislatures coming up next year, and nothing big is this Medicaid waiver thing, what is it, 2024, you said, Kenny? And so, getting these, has anybody here ever participated in the OHA peer certification program? Has anybody even seen that on the OHA website? And did they go through that certification? I have tried so hard to find someone that would explain that to me, so there you are. Because I agree so wholeheartedly. Once again, I will say that we can expect an understaffed behavioral health CMHP organization case manager to do all the work that is needed for a person with SPMI living off-site, away without internal on-site supportive services. We can't expect them to do it all, but we need to improve our communication methods between property management and case management and those people in between. And it's interesting that Kenny told me that, who is it that they gave you the contract for the Medicaid, your organization?
CCO.
Yeah, the CCO gave it, and the CCO in our area gave one of the service agencies that contract, not the CMHP. So there's so much for us to learn about who's doing what, where, and put our little potential plan together for who to be in touch with, and then how to communicate with them. Because I hear the horror stories, and you all have them. We're not going to dwell there, but you all have horror stories that we think that very simply, when the case manager visits one of our clients living in one of our housing units, we need a little report, simple little online report that says, I visited on this day at this time. This is what I found. It goes securely to the property manager who keeps confidential records. And we just have a running report, because we've had people die in our units and the case manager says, well, nobody would let me in. Well, guess what? They're dead. And so, I mean, there are just lots of little elements. So anyway, here's what I want to ask of you. Do you want this discussion to perhaps continue at the Housing Oregon level in a subcommittee? Okay, good to know, because I've been talking to them about that, and we can keep an agenda so that we don't waste our time. And that's why these reports are really important. So they will help focus on that agenda. And then, and here's the thing, this is hard work. And I was going to say when you first showed up, I said, if for those of you who thought you were coming to this session for your own mental health, you are not incorrect. Because this is very hard work. And I had to realize in working with this huge group of behavioral health people that they were so stressed out. They're frontline workers and they were so stressed out. And so it's very important that we support one another and respect and appreciate the hard work that everybody's doing in this regard. And so that I already talked about secure resources to examine best practices. That's that graduate student program that I want to try and bring forward with the Willamette Health Council to do some, especially assessing how this is working in rural areas where you have mostly off-site supported housing with not clinical services on site. That's a big lift right there. So anyway, any questions? Oh, they're always going. I love that this man from this Native American man was in one of the sessions and he talked about, this is a process, and even when you get to the end, that's still the process. So this is ongoing. So thank you very much for your time. You like it? Thank you, Jim.
Your email and I will run it.
Oh, you are so nice. Yeah, it's D here. I'm going to give you my name. So it's going to be D with the last name at polkcdc.org. And I'm going to get that one from her. Thank you, Kenny.
Yeah, no problem.